Welcome to today's session titled Conversations with GIA, COVID-19 and Long-Term Care, Preparing and Supporting Families and Family Caregiver. Before we get started, I would like to go a few items in order to participate in today's event. When you join today's webinar, you selected to join either by phone call or computer audio. If for any reason you would like to change your selection, you can do so by accessing your audio pane in your control panel. You'll have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may submit your questions at any time. We will collect these and address them during the Q&A session at the end of today's presentation. I would now like to introduce John Feather, CEO, Grantmakers In Aging, and moderator for today's webinar. John?
Thank you very much, Sam. And we want to welcome all of you. We have over 300 on the call today. So this is clearly a topic of great interest at this time. I also want to thank the Johnny Hartford Foundation for their continuing support of not only today's webinar, but our entire webinar series. Older people and people with underlying health conditions are at elevated risk of serious illness and death from COVID-19, particularly the 1.3 million residents of nursing homes and other institutional long-term care facilities. By some estimates, many long-term care facilities will experience an outbreak of the virus, and transfers to hospitals may not be an option. And the death rate may even exceed 20%. Many families and family caregivers are unaware of the scope of the challenges associated with COVID-19 in long-term care facilities and lack resources to help prepare themselves and their family member, both mentally and emotionally, for the possible impact. Geriatricians and long-term care providers are urging all families and caregivers of older adults, particularly those in long-term care, to understand their options and to act now to engage in meaningful conversations with their loved ones about care options as well as preferences for end-of-life care if that is needed. On today's webinar, we are very pleased to be able to hear from two great speakers, a noted geriatrician and healthcare policy researcher, and an industry leader in the long-term care field, so that we can learn about how funders can support care facilities, family caregivers, and communities in coping with the stress and impact of COVID-19. We are very pleased to have today Dr. Joanne Lin, who is policy analyst at the Altarum Center for Elder Care and Advanced Illness at the Altarum Institute, and also Katie Smith-Sloan, the president and CEO of Leading Age, the largest network of not-for-profit organizations representing the entire field of aging services, and also executive director of the Global Aging Network. We thank you both for joining us. As was mentioned earlier, you can enter your questions for our panelists at any time in the question box, and I will be collecting those and reading them to our panelists when we get to the question and answer period at the end. So Joanne, let's start with you to share some national perspectives.
Delighted to have the opportunity. Go ahead for the next slide. And this is just our title, so if you need any follow-up, there's my email. Feel free to be in touch. Go ahead to the next slide. This is, for many of you, I know, just a review, but most of us will need long-term care. That is, care for more than a few months for personal care needs. This is quite surprising to many people who feel that they will somehow just get sick and die all in one sentence and all in 1 week. This is now very rare. Most of us will need long-term care, and those who do need long-term care will have an average of about 2 years of needing someone else's help most of the time for at least that long a period of time. 1 out of 7 of us will actually need it for more than 5 years. Considering people who are dependent upon other people for at least 2 of the activities of daily living, this is activities like feeding yourself, dressing yourself, getting to the toilet, moving around in your home, or who have serious cognitive impairment. This is the level at which people need someone else around essentially all of the time. Half of those folks live in the community, assisted by their family or by paid aides or both, and half live in assisted living centers or nursing homes. and more than half of the cost is in Medicaid. So that's just sort of framing issues. Go ahead to the next slide. So COVID-19 comes along, and it is a unique and perilous threat to people who are living with substantial disability. It is very contagious, including for on the order of 6 days before symptoms and on the order of 10 days after symptoms. And it turns out now that it appears that about half of people are almost completely asymptomatic. So this is a very contagious virus. It spreads by conversation, by coughing, by sneezing, by sort of being in the presence of another person. And it is not one that shows itself quickly. It is more deadly with increasing age. The figures aren't entirely clear, but something on the order of around 17% of people over 80 are dying with this. It is only about 1 or 2% in people 40 or 50. So you can see that there's quite a slope with increasing age. And people who are living in nursing homes or home care with similar level of disability are likely to be even more substantially dying. So the nursing homes that have had outbreaks in the US have been running 20 to 40% mortality. There's essentially no diagnostic testing outside of hospitals. There is a little, I wouldn't say there's none, but it is hard to get. So we are often flying blind, not knowing who has the virus in their aerosolized droplets. We really need serologic testing for having developed immunity. The people on the platforms keep saying it's coming soon. There are a lot of diagnostic or serologic testing for immunity that have become marketed, but they're still only serving on the order of 100 to 1,000 people a day, so that effectively most of us have no access to serologic testing. Within a month or two, I imagine this will be at scale and will be broadly available, but it isn't yet. And the settings of care, both at home and in nursing homes, had inadequate isolation equipment. So hospitals, of course, have been all over the news as not having enough isolation equipment, but nursing homes mostly just had gloves and surgical masks. And surgical masks are a little bit effective, but only cut down your likelihood of getting the virus by maybe 50%. So since it was 99% before, you're only down to 50%. Very few nursing homes had hoods. Essentially none had the whole spacesuit kinds of things that you're seeing on television. Home care has been even worse. Home care clearly had gloves, but not much else. So many home care agencies did not have more than a few gowns for the occasional person with an infectious bacterium. So COVID-19 comes along and it is spreading like wildfire. Go to the next slide. What can be expected? People who completely isolate themselves can mostly avoid it for a while. So if you can go home, have your food delivered, not have to go out for any reason other than a walk in which you don't run into anybody who wants to talk to you, you can avoid it. But everybody else is at risk. No one has the spacesuit kind of protective equipment that protects them from all contact, and everyone else has risks. Putting on masks, sure, we should put on masks just out of politeness, but in fact, viral particles go through most cloth masks. Surgical masks, the air goes around the outside of it. The risk of contact obviously can be delayed and reduced, but it's still going to be substantial. But nursing homes, in my view, just have no real defenses. There will be major outbreaks. I find it thoroughly maddening that our leadership keeps blaming nursing homes. The best that a nursing home can do is to delay the outbreak and then to try to slow the spread within the facility. But about 20% of nursing home residents will die um, unless we get an effective treatment very quickly or a vaccine. Once we've had widespread immunity, so all these 60 to 70-year-olds get the disease and survive it, then when they are 80 or 90, they'll have immunity and the illness will be much less threatening. But at the present time, everybody is at risk because no one had seen this virus before, so no one's immune. There are 1.5 million people living in nursing homes, so you can do the math and see that the estimates being given by our leadership on their daily briefings are probably overly optimistic. People at home face additional challenges. They have the insecurity of caregivers. Now, caregivers in nursing homes are very difficult. It's always been difficult to staff nursing homes, but there's at least an entity that is trying hard to find the people who will give the bed baths and turn the patients and do the spoon feeding. If you're being taken care of by your daughter and your daughter gets sick, you're in a tough spot. Or if you're being cared for by a paid aide and the aide is scared to come see you, either because they're scared you have it or they're scared that they have it, you're again really in a tough spot. And these caregiver issues for home care patients have really not been being considered in our national response. And of course, people at home have all the usual things of getting food in, getting waste out, all their other illnesses. So we could expect that this will be a very substantial illness. It turns out that those who survive a seriously symptomatic illness in old age have been very sick for on the order of 10 days to 2 weeks. So they're deconditioned and usually lose some function from the experience of surviving COVID. Go ahead to the next slide. I think that our senior leaders have been incredibly obtuse about the issues of family caregivers in nursing homes. They've been mandating that nursing homes take in hospital discharges, even if the nursing home thus far has managed to avoid having COVID-19. I think that's just crazy. Why would you put this virus into the nursing home any earlier than it has to have it? Going to the home is different. It depends on what the resources are at the home and whether there are people who have been through the disease already and who are able to take care of the person. Just in case anybody was not paying attention, CMS last Friday issued a more than $600,000 penalty to the nursing home in Kirkland, Washington, which from my observation tried valiantly to do everything they could when they ended up being the first outbreak in the country. Home care and nursing homes are generally not on the distribution list. Nursing homes have gradually gotten onto the distribution list, but only barely. A home caregiver is really going to have a hard time finding gowns and gloves and masks. CVS is completely out. They don't know where to get them. The planners and leaders have been acting as if we all only behaved, we could really stop this disease. They even talk about conquering it. And that makes it wrong. Somebody was wrong. Somebody was to blame when you get a whole family affected or you get a nursing home affected. And the guidelines that have been being distributed only deal with infection control. They have not been dealing with the rest of what we need to be doing. Go ahead to the next slide. So what would have been better? Great respect for nursing homes, home care providers, the families that are taking care of very disabled elders. And yes, keep the COVID-19 out as long as possible. Do the distancing wherever you can. If you can try to keep aides who are who do not have children at home, do not have much exposure going into the home care, watching for aides who have been through the disease and are now well and therefore are immune. They should have expected there to be outbreaks. They should not have been blaming people who are involved in outbreaks, but admiring their heroism and continuing to try hard to take care of people. If you're fond of the Jerry Powell podcast, there's one up today interviewing a doctor who was involved in an outbreak as just how stretched the staff was and how they tried so hard to serve the residents in their nursing home. Obviously, everybody needed more personal protective equipment. We needed the right masks, we needed gloves, we needed gowns. They needed to get out to families, to family caregivers, to home health agencies, to nursing homes on the same schedule as they got to hospitals, rather than somehow assuming that they didn't need them as much. We need the diagnostic and the serologic testing. We need to know who has the disease and who has had it so that we can match people up in more intelligent ways. There has been some conversation now about advanced care planning in the context of COVID. So this is not just sort of, gee, how do you want us to handle when your mother may in the future get sick, or when you yourself may get very sick. Now there is a clear and present danger. This disease can get you very sick within 24 hours. We need to know what suits your preferences. Would you want to be in an intensive care unit? And if you want to be in an intensive care unit, you do need to know that the survival rate for people over 80 appears to be something around 20 to 30%. And people are quite, they have increased disability for having been so sick. If despite all that you want to do it, we'll try, but at some point hospitals may be overwhelmed and there won't be ventilators for everybody. If you instead want to stay in home or in a nursing home or an assisted living center, wherever it is that you live, then here's what we can do to make sure that you are as well supported as possible. Can we get oxygen to you? Can we get symptoms managed? We need to all be willing to say we need opioids. If a person is very hungry for air, you really need to be able to have them not feel so desperate. And that requires morphine or its equivalent. Thus far, there's been no leader willing to say any of those words, and I find it very strange. We need the skills and supplies for end-of-life care on site. Hospice can do that, but obviously hospice programs are likely to get very stretched, so we need others to be able to pitch in. Obviously, we need relief from some regulations, and CMS has been doing a good deal of that. And we need, once we survive this one, to include home care and nursing homes, and for that matter, the representatives of volunteer family caregiving to be involved in disaster planning rather than it being almost entirely EMS and hospitals. Go to the next slide. So what could philanthropies do? This is not my specialty. I don't know exactly what you could do, but there's some ideas here. There's some immediate help. Robert Wood Johnson Foundation just announced that they're putting out $50 million in urgent help to a number of charities that are key to kind of keeping people well supported. So rapid response to critical needs. The Stupski Foundation in the San Francisco area has put up a page of all the resources in the San Francisco area that are available to help you. I would say there's some intermediate term help, support to aides and nurses, promotion of serologic testing, supporting worthy facilities and agencies that suffer major setbacks. Let's try to keep the most valuable elements of our communities alive. And then in the longer term, you could really be a voice to insist that the considerations of people out of the hospital need to be involved in disaster planning. We need to develop, maybe out of this endeavor, some ongoing management of how well the community is doing in elder care. Let's measure how many families are being bankrupted, how many people have to leave work, how many people get a pressure ulcer, how many people die in pain. I mean, whatever it is that's important to your community, we have not done much in terms of knowing how geographic communities perform in taking care of elderly people. And we need to evidence that we value these services and those who perform them, especially the very underpaid aides. The average aide in this country still makes under $12 an hour and does not have benefits. This is one of the hardest jobs in the community. We really need to upgrade the situation for direct care workers in nursing homes and in homes. And then we need to really pay attention to retirement financing. We're going to have many people coming into old age having depleted their savings. We need to have housing that can handle people who can't take steps, who need wider doorways into their bathrooms. Disability housing needs to be much more pervasive. We need to work on the workforce. There are only something like 7,000 geriatricians in the country. We have a shortage of workforce at the aide level everywhere. And then the supportive services. It is outrageous that we, at this point, have many cities with waiting lists for home delivered food, for example. How can you have a 6-month waiting list for home delivered food? That's really hard to handle. Go ahead to the next slide. And the next one. So, I think we really need a very deliberate approach to making the future that we want. We built Medicare in 1965 when the average age at death was in the late 60s. The average causes of death were fairly abrupt. Most people owned a home. Most people had a pension. These things are all different now. Most of us who make it to 65 will make it to 80. We will have on average 20 years of retirement. We haven't redesigned our retirement savings. We haven't redesigned our elder care arrangements. We have just drifted into a situation that already was very perilous and now is desperate with COVID-19. Go ahead to the next slide. So I put together a couple of resources. I understand they're going to send the slides out, so you don't have to try to write these down. But I wrote a pretty strong blog in Health Affairs that's public, and advice to nursing homes on Medicaring.org. Those are both pretty easy to find. I stuck up here the Stupski Foundation's website for all the information in the San Francisco area. I don't think Robert Wood Johnson Foundation has a similar resource yet, but this is an interesting, very inexpensive idea that some of you may want to take up, especially if you're really anchored in one geographic community. And then many of you are in the position of needing to talk to your own relatives, your own elderly people, or you're elderly yourself and you need to talk to your family. The Conversation Project has put up a very nice guide for the public. There are lots of others for professionals and clinicians, so I didn't try to do all those. So go to the next slide. I always like the Buckminster Fuller observation. Let's build the new models. Once we survive this endeavor, or most of it, there will come a time when the hospitals are not overwhelmed, when we're not doing a 24-hour news cycle of terrible stories and what's going to happen next. And there might be a few opportunities to really do it better. And I think that we need to spare, a tithe portion of your time, a tenth of your time, to think about what would really work well in your community. And let's be in a position to get it achieved. Thank you very much. I look forward to the questions. Go ahead to the next person. Next slide up. There you go.
Katie, it's up to you.
Great, thank you. Thanks, John. Thank you, Joanne, for setting the stage. I thought I'd start with just a word about who Leading Age is. So we're a national association, been around for almost 60 years, and we are comprised of about 5,500 community-based, not-for-profit organizations around the country. And our members provide, there are nursing homes, there are home health, there are hospice. We have a new affiliation with the Visiting Nurse Association, so we have a lot of home health and hospice. We have PACE programs, adult day, affordable housing, assisted living. So it's really the full sort of panoply of services and supports for people as they age. Next slide. Our members are on the front line of the pandemic, there's no question, largely because of who they are and what they do. So they're serving older adults that often have multiple chronic conditions, frail, in whatever setting they may be. Next slide, please. The biggest challenges for aging services providers, and Joanne has mentioned these as well, are access to personal protective equipment, access to testing. Funding is a huge challenge for everything, but particularly for nursing homes who are now needing to create isolation units for people who test positive for COVID-19. That creates additional staffing expense, additional sometimes physical plant reorganization expense. Staffing, which I'll talk more about later, has been a challenge and continues to be a challenge. And then really the challenge of creating a safe environment for those who are living independently, whether that's in assisted living or affordable housing or in their own homes, creating that kind of safe environment where they're very used to coming and going and not being as confined as you are in a nursing home. Next slide, please. Joanne mentioned this, but nursing homes are much in the news, and I think in part that's because the first COVID deaths began in Washington State, in Kirkland, Washington, in a nursing home. But you know, nursing homes do have the advantage of having stringent infection control policies and procedures in place, and have for years. They're required to, as they should. They have the advantage of having clinical staff. They have medical directors. So really, in many ways, they're among those in the aging services continuum. They're the best prepared for something like this. They prepare every year for the flu and are really part of the solution. So what's challenging for nursing homes is that very often they have staff who work elsewhere as well. So they may be a speech or physical therapist who may work at multiple settings, or a certified nursing assistant or a nurse that works in multiple settings. And they're coming in and out of the nursing home to provide services and supports for those residents. And as Joanne mentioned, this virus is simply insidious. I think there is perhaps, hopefully, optimistically, beginning to be a recognition, at least in some places. Nursing homes are pulling their weight here. There was an article in Politico this weekend, and the headline was that the public health has failed nursing homes, and I would fully agree with that statement. Still, the situation is hard. No visitors. They're all screening all their staff, all shifts. They're learning where else they work. They're creating COVID units and wings by moving residents around or repurposing empty space. And truly the travesty has been their lack of access to protective equipment, masks, gowns, gloves, and the lack of testing. And without that, neither staff nor residents can be protected from the virus. Next slide. But as I mentioned at the outset, Leading Age has a very diverse group of members, and there are other settings besides nursing homes that are worrisome in this situation. Assisted living, independent living, and affordable housing don't have the same kind of infection control policies in place. They don't have clinical staff. Affordable housing hardly has any staff at all. And residents are living on their own. They have their own kitchens. They're preparing their own meals in many cases, not always in assisted living, but and they're coming and going. and very used to doing so. Many of the instances of COVID-19 that I've been hearing about from our members are in affordable housing. And all those who manage them are trying to convince their residents to shelter in place by doing things like closing their activities rooms and taking furniture out of lobbies. It's still very hard to do. In some cases, older adults in affordable housing have served as the daycare provider for a grandchild, which means a lot of coming and going from a number of places. Each time that happens, it increases the risk of exposure. So while all eyes are on nursing homes right now, I have to say that I'm just as concerned about people living, older adults, frail older adults living in other kinds of congregate settings. Next slide, please. Just a word about adult day centers, which I think play an incredibly important role for older adults in the communities, and a really important role for families, family caregivers in particular. And sadly, these are closing. Many adult day centers have simply not been able to create the kind of safe environment for the people that they serve to be able to stay open during this virus. And it's creating a serious gap in service for many individuals and families. We have I heard about one adult day program in one state that had to close. A nearby nursing home offered to take those individuals and create sort of a makeshift adult day center in the nursing home, and they were unable to do so because the adult day program participants were considered visitors and they were prohibited from having visitors. So we're creating some of our own unfortunate barriers. Next slide, please. That said, I don't want to be Debbie Downer because there is amazing dedication happening. There are members in all settings, including in people's homes, are showing this deep sense of commitment and determination to protect and support those who are part of their community. You know, when I talk to members, I hear words like nightmare, horrific, and frightening. And then you juxtapose that against their commitment and their compassion. And I see that when they decide to spend the night in their communities, working around the clock instead of going back and forth, perhaps creating the risk of bringing in the virus. I see it when they're scrounging for protective equipment. We're taking on roles that they never expected. CEO becoming a procurement officer, showing up to greet every shift, even if it's at midnight, and providing meals for staff to take home to their families. Working in isolation units is hard work, and yet they're doing it. So it's just, you know, in many ways, nothing short of inspirational and heroic. Next slide, please. So what's happening on the ground? I mean, Joanne really described this with some great data points. There are outbreaks in hundreds of communities. The staff are getting sick along with the residents. Some communities haven't gone a day without a new case, and that is assuming that they can get access to testing, which is a real challenge in many communities. Organizations are setting up COVID-only units, which sometimes a floor, another times a wing. Sometimes it's short stay rehab rooms that are now vacant. And often it means moving other residents around to be able to create that protected environment within their facility. And some are simply assuming that everyone has the virus and are behaving that way with protective equipment all the time on everybody. But they do understand that they can't control everything. So they're working hard to control what they can. And they're recognizing that now is the time to lead and to manage, but not to control. Next slide, please. So I thought I'd give you a sense of the day in the life of one of our members. He wrote me an email and he said, today I took care of 700 residents. I opened, filled, and staffed a COVID recovery unit with 22 beds. I provided home, meals, and support for 130 residents in one building and comfort for 100 low-income residents in another. Staff came to work. We fed our staff. We straightened out the security company. We provided our staff with the equipment they needed. We did 250 family FaceTimes, because families can't visit. We pursued emergency funding measures, got a waiver for a new medicine dispensing machine, updated the board, hosted 2 family webinars, found and implemented a new heavy-duty cleaning company. All our staff received a paycheck. We laid off and furloughed nobody. We supported our staff in every way, and then some. So just an example of how difficult it is to run one of these. In this case, this was a nursing home that also had some affordable housing. Hard work. Next slide, please. So as often happens in times of crisis, people come together and they innovate, they creatively problem solve. In one region, several member organizations are banding together to turn an empty nursing home, which was planned to be demolished, into a COVID-19 facility. Some are providing beds, others are providing equipment, the states are providing some funds, and then they face the big question of where to find the staff. In another, a member organization is working with the state and the referring health system to open a specialty unit. And it really does take all working together to get the needed protective equipment, to get the regulatory relief, to find the staff and get access to full-time medical direction. There's a lot of sharing of information about where people can access masks and gloves and gowns right now. There's a lot of problem solving together and a strong sense of community that we're all in this together. We're also working closely with hospitals, and we have been really clear that nursing homes are willing to take COVID patients as long as they have sufficient staff, the ability to isolate, and sufficient protective equipment. Because if they don't, they can't keep their other residents and staff safe, and they'll simply end up sending more people back to the hospital. Next slide, please. So staffing, I've mentioned it a couple of times, it's a challenge. It's a critical problem. It was before and it is now. Some of the challenges that our members are facing are childcare centers closing, and where are they going to get the childcare and go to work and meet their personal life needs? Getting sick themselves, fear, anxiety, and just the need for more staff now. Now that nursing homes and other communities are not allowed to provide congregate meals, communal meals, they have to deliver meals directly to individuals' apartments or units or homes. You need more staff to staff an isolation unit and staff to simply cover the gaps. So we've taken a few steps at Leading Age. We are leveraging our National Career Center and have formed some national partnerships with companies that have displaced workers in the restaurant and hotel business, and we're trying to use that to match supply with demand. We're also partnering with a small startup called Next Steps to make available a short training program on COVID-19. We're doing this in partnership with the National Domestic Workers Alliance as well, recognizing that whether you're working in a nursing home or you're providing home care in a private residence, you are on the front lines. So this training includes things like how to protect yourself from the virus, instructions on how to don and remove your protective equipment, how to take temperatures and tools for managing stress and anxiety. It even has a guided meditation. And it's delivered on your phone in bite-sized pieces. And it's just one of the many, many ways we can support staff at this time. So what else are people doing? There's some members that provided a food pantry for staff to access the basics. Others are sending meals home with staff. And many others simply don't have the bandwidth or the resources to do that and certainly could use help. I got an urgent email from a community service member over the weekend saying that their food pantry was running on empty and to drop off anything we can spare to support older adults living in the community. So these needs are real. Next slide, please. I have to say a word about mental health and wellness at this time. It's an overarching issue. It's an issue for families. It's an issue for staff, leaders, residents, and clients. just simply addressing the mental strain that comes with fear, with death, with uncertainty, and with all of the unknowns that we're faced with right now. So one of the biggest needs I see now is for counseling online, because that's the only way we can do it, that can help people cope with and deal with the stress and strain that they're under. Joanne mentioned end-of-life issues, and these are challenging right now, and they're hitting all settings, and they're often hitting in clusters with no time to process individually, much less collectively. So what people are experiencing, especially those on the front lines, is a form of trauma, and it will be with them for a long time. So we need to address this head on and soon. Next slide, please. So another big issue, and it's really connected in many ways to the issue of mental health and wellness, is this whole notion of connectedness. Being together, connecting, is a completely human experience and need. And right now we're forced to be apart, and anxiety sets in. So when family members can't visit their loved ones in a nursing home, or in assisted living, or in affordable housing, anywhere they live, that creates anxiety. So we need to employ all the tools that technology can offer to find ways to make sure people stay connected, whether it's tablets or phones or apps. Seeing a face, talking to a loved one goes a long way. And the lack of ability for family connectedness, particularly at the end of life, when all the rules have changed, is particularly difficult. So we've seen heroic effort on the part of many of our members in using technology to make sure that families do stay connected with FaceTime and Skype and WhatsApp. But regrettably, many organizations are simply too small or too poorly resourced to be able to make such technologies available, especially in housing that serves low-income older adults, where there may even be problems with adequate bandwidth. So that's a huge issue that I think for which there are solutions, and the solutions fall in to technology. Next slide, please. And finally, just a word about how we fit into the broader healthcare system. It's a symbiotic relationship. We're all in this together, and flexibility and agility is key without putting anyone in harm's way. So with all the focus on hospitals and acute care, which is appropriate, we just simply can't ignore the essential role that providers of older adult services play. In fact, older adults spend far more time tapping into the long-term care service infrastructure than they do in hospitals, in good times and in bad. So we have been urging our policymakers to not ignore the critical role of service providers and family members as they prioritize support during this difficult time. And I'll just close by saying, as one member said to me recently, every day we do what we can to take care of residents and staff. We know we can't control everything, so we control what we can. And we remind ourselves that there will be a point in time when this will be behind us. Thank you. Back to you, John.
Hi, this is John Feather. So we're moving on to our question portion at this time. And we want to thank our presenters. We have a number of questions, but remember that you have the ability to write in questions in the question box that you see on your screen. So please do so at this time. We have a number of questions for each of our panelists. So we'll start with you, Katie, and say that the question's about how can we elevate direct care workers, and which we knew was an issue before and now is critical. Could you say a little bit more about the national partnerships that you're engaged in around this?
Sure. So the one partnership is with Next Steps and the National Direct Care Workers Alliance, and that really is focused on making sure that people who are in the direct care business have have the knowledge and the tools that they need to be able to navigate COVID-19, whether they're a home care worker going into an individual's home, or whether they're a CNA or nursing assistant working in a nursing home, that they really, or assisted living, that they understand just the very, very basics to protect themselves, but also to take care of themselves. And then the other partnerships we've formed have been with national organizations that represent the hospitality and restaurant industry for the most part. Many people have been laid off or furloughed and are looking for jobs. And there are jobs in nursing homes, assisted living, and elsewhere that are involved with housekeeping, with food service. There are streamlined training programs for nursing assistants so people can get a lot of on-the-job training. So we have a huge need for staff right now, and there are ways of identifying those staff.
Thanks. Joanne, anything to add on that around that, how we can help direct care workers and meet this need at this point and then into the future?
Well, one avenue that is only beginning to be talked about is to get serologic tests on everybody that might be working in these settings, nursing homes, home care, the assisted living settings. And once a person is immune, then they are quite valuable. They no longer can spread the disease or get it. So I think that we probably ought to be paying something of a bonus for those folks to really take up work, provide the child care, do whatever you need to get people who have proven immunity being available. They could work in COVID wings of a nursing home and never get it or spread it. So I think that's another angle. And then in the long run, we need to professionalize this work. There's no reason why this country pays less than a living wage for this very hard work. It's just that it's women doing it, and we've just always accepted that it's okay to pay. Washington D.C. pays $24,000 a year for full-time frontline care aides. We've got to change how we finance things so that is more like a living wage. $24,000 is not going to get you very far. So most of the aides working in my city have to work 2 jobs, which of course also spreads COVID.
Yeah, and let's stay with that for a second, and with you, Joanne. So, a question about policy work. So, we're trying to deal with the immediate impacts now. What do you see as some of the important policy implications and things that we need to press for going forward, so that both, in the next year when this will still be playing out, but then in the future, what would your priorities be?
We need a serious redrafting or reformation of our long-term care financing and service delivery. We will have so many people now coming into retirement with thoroughly inadequate finances. And then, after 16, 18 years of retirement, they'll hit serious illness and disability and have nothing. So are we really going to finance all of this through Medicaid, or are we going to encourage a savings plan, a social insurance scheme? What are we going to do about Social Security, which already was due to begin to have no money in the trust fund in 2026? And now with the economy faltering, that will come quicker. So we really need an urgent conversation. We built our arrangements around elder care at a time when most people did not have a substantial old age. Most people died before they were 70. Now we really need a very different set of arrangements, and that will require an awful lot of public awareness, putting good ideas on the table, having them debated, having the public get really excited and invested in getting enduring solutions, not just a stopgap for today. We basically doubled the national debt in the last couple of months. Where was that money when we were talking about trying to salvage Social Security? So in the policy arena farther downstream, within a few months, we really need to be moving to what are the worthy ideas? How do we get people to be aware of them and to be behind them? It is not Medicare as a single payer or Medicare for all that's going to handle long-term care, because long-term care has never been part of Medicare. So we need a very different conversation about how we're going to take care of one another with disability when younger, and with most of us getting disabled in old age.
Thanks. Katie, how about you? What's on the policy agenda for leading age at this point?
Yeah, I would fully support Joanne's comment about the need to develop a system to finance long-term care in this country. We don't have one. So it's either Medicaid or it's family pocketbooks. And I think we're heading towards a situation where Medicaid can't sustain that, and neither can family pocketbook. So now is the time to begin in earnest to have that conversation and create the political will to do something about it. I think another just a critical issue facing us is the need for affordable housing. There's a huge rise in the number of elderly homeless, and part of the reason for that is we simply don't have enough affordable housing in this country. We need to address that, and we need to make sure that when we build housing, create housing, affordable housing for older adults, that we wrap services into that so people can live safely for as long as possible. So those are two huge priorities for us in the coming years. But I also would say that I think, with this COVID and with some of the changes that have happened, particularly with telehealth, I think we're going to need to, it'd be interesting to take a hard look at how that has impacted care delivery and how it could in the long term, and what are the opportunities perhaps that create, and what are some of the issues that we need to address around that.
Well, thanks. I'll stay with you for a moment, Katie. Several questions around the issue of how this is playing out in rural communities, and where in many ways challenges are more daunting even than in urban communities, but hasn't hit as hard yet. What are you hearing from your members who work in rural communities?
Well, members in rural communities have always been challenged by the staffing issue, simply because of where they live and access to staff. And I think they're anticipating that will be exacerbated when COVID hits their communities. Will they be able to access enough staff? So they're doing a lot now to try to incentivize staff to stay with them, to try to keep their staffs safe. Rural providers have always been good partners with hospitals because they have to be, and I think those partnerships will strengthen. But the challenges that they have with getting enough staff to do the work that needs to be done on a normal day will just simply be exacerbated, and they're already concerned about that.
Joanne, anything to add to that?
Well, I would certainly underscore what Katie had to say about the housing. There are countries and even some states now that are insisting upon all new housing being accessible to a person in a wheelchair. That'll take 20 or 30 years before we have any substantial amount. But right now, one of the hardest things to find for a disabled person is a place to live. And then her second issue of, can you find a place to live that's affordable? And then the third is, can you find a place that's accessible, affordable, and has some services? And we really need to be redesigning our housing to do that. And then the questions of how to engage the public and have people get behind some of the winning ideas. Still almost half of the public believes that Medicare covers long-term care. They find out otherwise when the first person in their family needs long-term care, and they find it out quite cruelly. It's now the biggest cause of personal bankruptcy, and probably even a bigger cause of going into Medicaid. So we really need to be redesigning our system to the new realities. And there may be some opportunities to do that if we lean in to do it as COVID starts lifting its claws and allowing us to go back to thinking ahead.
Well, thank you. We have some other questions, and we are going to be forwarding those to our speakers. But at this point, as we come close to the end of the hour, I'm going to ask each of our panelists for their final words of wisdom. Katie, could we start with you?
Sure. Thanks, John. Well, as I said, these are extremely challenging times for those who provide services and supports for older adults, regardless of the setting that they're in. And obviously, those in congregate settings are particularly at risk because of sheer proximity. And sort of the irony of this is some of the very positive changes we've made in nursing homes in recent years and converting long, double wide corridors into neighborhoods and greenhouses and small houses, which have all been so positive for increasing the quality of life of those residents, are creating a heightened challenge for nursing homes at this time. So I would just say we as a nation, as states, as communities, must really recognize and lift up the essential and unique role that they're playing on the front lines, including the role that family caregivers are playing, and do all we can to support them. The challenges that these providers faced before the virus, with enough qualified staff and inadequate funding, have been simply exacerbated by the current circumstances, and they deserve our support and our appreciation. So thank you.
Thanks so much. Joanne?
I think I would underscore the remarkable dedication of the frontline caregivers, both professional clinicians and home health aides and housekeepers, the janitors. The degree to which people have continued to come while faced with a potentially lethal illness is just really heartwarming. Why do you show up over and over again for a $12 an hour job that puts you and your family at risk? And yet most people are showing up as long as they can. Everyone's making heroes of the EMS and the hospital folks, but we need to recognize the heroism of people who are working in traditionally scorned settings or isolated settings, the family caregivers who no one recognizes are around. We need to expect the outbreaks and the deaths and honor the best possible arrangements without threatening them with big fines or lawsuits or any of those things. People are trying hard to do the best they can in very difficult circumstances. So if you're running a foundation, I would encourage you to help now where your community needs help. If you're working at a national level, there are national opportunities, but also spend some time planning for the future. What is the future we wish to carve out of the opportunities that will arise as we reshape the delivery system and the financing arrangements? We really could start trying to make sure that long-term care is reliable, affordable, that people can live comfortably and with meaning through to the end of their lives without being homeless, without being ignored, and that their caregivers are considered to be very valuable. So it's a big agenda, but I hope each of you can pitch in some ways, and I'm sure Katie feels the same. Let us know if you see a clever idea or you run up against an implacable barrier, and we'll see what we can do to help.
Thank you so much. I want to thank Dr. Joanne Lynn and Katie Smith-Sloan. We thank you for all that you do in this particularly difficult time, to support care facilities, family caregivers, and communities in coping with the stress and impact of COVID-19. I also want to thank our team here at GIA who pulled this webinar together in less than a week. And also for all of you, the 300 of you that are on the call today with us, we are trying to do these in a very timely way, and we appreciate the willingness of our speakers to come on very short notice. I also want to thank the Johnny Hartford Foundation for their continuing support of this webinar series. As was mentioned, we will be making today's presentation available for anyone who wishes to view it later, including both the slides and the audio. Watch for an email to be sent out within a couple of days. And finally, we want to thank all of you for participating in today's webinar. Please stay safe.